شايفين السكرين يا شباب؟
واضح يا دكتور.
ايه واضح.
واضح.
Portion of orthopedics. You have to know details of function, details of anatomy, and details of conditions that affect the hand. The hand is considered by some as part of the brain. It functions by prehension, meaning, yeah, the brain sends the message. The shoulder and elbow put the hand in such a position so as to function. And if you look and study the hand carefully, you see that the sensation in the hand is such that you can identify objects. Blind people make use of the hand to read. Others make use of the hand to caress their. So the hand is a very important structure. I will be going very quickly on many topics in the hand because it's such a long topic and it is a course in itself. Yeah, the people take it for a period of 1 week. I'm going to try and give it to you in 3 hours. The human hand, as an extension of the brain, allows us to manipulate and interact with the environment and to perform activities as routine. It provides tactile sensation for complex hand movements without the necessity of constant visual guidance. Many times when you want to reach for an object, you'll be looking at one way, and your hand is this function is epitomized by blind people who read and musicians who entertain. Briefly, anatomy and biomechanics. The carpus or wrist is composed of 8 carpal bones that link the forearm to the hand. The proximal carpal row, the scaphoid, the lunate, and the triquetrum, not forgetting the pisiform, forms the proximal row. And these 4 carpal bones articulate with the distal radius and ulna, as well as distally, it articulates with the trapezium, the trapezoid, capitate, and hamate. If you look at this sketch, you see that proximally you have the scaphoid, the lunate, in between the distal radius and the distal carpal bones, which I have mentioned. Now, distant to these, you have 5 metacarpal bones. Then after that, you have 5 phalanges. The difference between the other regions of the thumb is a saddle-shaped joint, a configuration that permits abduction, adduction, as well as circumduction that permits opposition of the thumb to the fingers. The metacarpal phalangeal joint proximal, interphalangeal joint, the proximal, and the distal interphalangeal joints basically are flexion extension joints. They are hinge joints. So the difference between that of the thumb and the phalanges is that one is a saddle joint while the other is a hinge joint. The skin on the dorsal surface of the hand. حتى إيه تكونوا شدوا حسوا الجلد. The hand is thin. It is flexible to allow full flexion of the fingers. Whereas the palmar surface تطلعوا من قدام وبتدسوا بتلاقوا الجلد, you cannot kink it. The volar crease and the proximal volar crease, and the proximal scaphoid and the pisiform are in line with the distal volar crease. إذا بتشقوا على distal volar crease بتلاقي دغري تحت منهم موجود السكافويد and the pisiform. The distal palmar crease of the hand corresponds to the MP joint. And these would help you tremendously while you're doing surgery on the hand. The extrinsic muscles of the wrist and hand originate on the medial and lateral humerus, also from the proximal radius and ulna. So you have to know these by anatomy. You have to know where the distal volar crease know briefly about the type are hinge joints. The pisiform is another story. It is part of the proximal row, which I've mentioned to you at the beginning, but we should consider it as a sesamoid bone in the flexor carpi ulnaris tendon that articulates only with the trichitron. The bones of the hand are the metacarpals and the phalanges. So I mentioned to you that the carpometacarpal joint of the thumb is a saddle joint. طلعوا بالصورة على جهة اليمين بهالسلايد. You can see what I mean by a saddle joint. It is a configuration that permits abduction and adduction, as well as circumduction, rotation of the whole thumb, it's drawn by demonstration in this slide. You have abduction, adduction, and circumduction. The whole purpose is to be able to bring the thumb pulp opposite to the pulps of the other fingers for opposition, for function, for use. The extrinsic muscles of the wrist and hand originate on the medial and lateral humeral condyles of the radius and ulna, and the proximal radius and ulna, I'm sorry. Extrinsic tendons, the extensor tendons cross the wrist, and they are surrounded by tendon sheaths. 6 compartments on the extensor surface of the wrist, and these are bounded by the extensor retinaculum ligament. This shows you the 6 compartments, and we all know, I'm sure you all know, what the first compartment consists of, which is of the abductor longus and the extensor pollicis brevis. The second compartment involves the extensor carpi radialis brevis and longus. The third compartment consists of the extensor pollicis longus. The fourth compartment, the extensor communis, plus the extensor digiti minimi and extensor incis proprius, while the fifth compartment consists of the extensor digiti minimi and the and for surgical problem. For instance, we have to expose the first compartment when we are dealing with a decurvens tenosynovitis damage the extensor pollicis longus. So you have to keep this in mind. This is a transaxial view showing you the compartments where you have the extensor pollicis brevis, abductor pollicis longus, etc. As I mentioned, I'm not going to prolong this any further. Keep this in mind. This is a question that comes in the board asking about what are the contents of one of the compartments. The extrinsic finger and some flexor tendons and the median nerve enter the hand through the carpal canal. The transverse carpal ligament is a thick band and pisiform to the scaphoid and trapezium, and this forms the inelastic roof of the carpal canal. A decrease in the size of the canal or an increase in the size of its contents can cause compression of the median nerve, leading to what we all know is a carpal tunnel syndrome. This shows you the contents of the carpal tunnel, consisting of all the contents within the compartment. This shows you the nerves that pass through the carpal tunnel, leading to the carpal tunnel syndrome. Likewise over here. You can see side by side with the carpal through which passes the ulnar artery and nerve. Okay, I just want to take point. Okay. Intrinsic musculature includes the thenar, the hypothenar, and the interosseous muscles. The thenar muscles, which are the muscles about the thumb, they are the abductor pollicis brevis, the opponens pollis, and the superficial head of the flexor pollicis brevis. The deep head is supplied by the ulnar nerve. The adductor pollicis of the thumb is supplied by the ulnar nerve, while all the rest are supplied by the median nerve. Keep this in mind. These are questions, again, that the hypothenar muscles are composed of the abductor digiti quinti, the opponents digiti quinti, and the flexor digiti quinti, and are well demonstrated in the slide, more or less on the below slide, but the above slide demonstrates well the thenar muscles. The dorsal interossei are supplied by the ulnar nerve, and they are mainly involved in abduction of the fingers, while the volar are involved in adduction of the fingers, and again supplied by the ulnar nerve. This shows you the interosseous muscles, where they function in abduction on the dorsal and adduction on the volar surface of the palm. The DIP joint of the fingers is flexed by the flexor digitorum profundus. It has a separate muscle belly for the index finger, but a common muscle belly for the long, ring, and muscle and small fingers, which tend to work as a single unit. So keep this in mind. You have to know that there is a separate belly for the index finger, and the rest are together. So the index finger can function individually, while the long, ring, and small fingers function as one. The PIP joint, or the proximal interphalangeal joint of the fingers, is primarily flexed by the flexor digitorum superficialis. This shows you the flexor digitorum superficialis as it arises from the epicondyle of the humerus and the coronoid process of the ulna, and and wrist. Okay. It has individual muscle bellies for each finger, thus providing the individual finger flexion at the PIP joint that is necessary for activities such as playing a musical instrument and typing. Two parts as it reaches the proximal phalanx on the anterior aspect before it inserts on the base of the middle phalanx. The flexor digitorum profundus enters in between the split of the flexor digitorum sublimis. This shows you the tendon of in the middle slide, the tendon of the sublimis dividing in two, and then you see the longus, the profundus, enters in between both divisions and goes to insert on the proximal end of the anterior aspect of the distal phalanx. Both finger flexors are enclosed in the common tendon sheaths. And this is bad because you see that there is a no man's area where if you get an injury and these become inflamed, they form an adhesion and they limit flexion and extension of the fingers, secondary to scarring and adhesions. Now, the sheath promotes efficient movement, but adhesions from injury or infection can be problematic in this region. The interossei, along with the lumbrical muscles, flex the MP joints and extend the PIP or proximal interphalangeal joints and the distal interphalangeal joints. The lumbrical muscles are unique in that they originate from the profundus tendons to insert on the dorsal apparatus of the antagonist extensor mechanism. The interossei and two lumbricals are innervated by the ulnar nerve, but two radial lumbricals are innervated by the median nerve. The lumbricals are divided, they have four lumbricals. The ulnar two or the medial two are innervated by the ulnar nerve, while the lateral two are innervated by the median nerve. So I repeat so that it will go into your mind. These on the left-hand side, they are the interosseous muscles, and they join the common extensor tendons. They flex the MP joint, and they extend the middle and DIP joints. Fundus comes to the front. It passes in between two heads of the which are inserted into the base of the middle phalanx. It goes distally to insert on the base and anterior aspect of the distal phalanx. The metacarpophalangeal joints of the fingers are extended by the extensor digitorum longus, the extensor indicis proprius, and the extensor digiti minimi. I would like to remind you that these pass through the fourth compartment, the extensor compartment. When the metacarpophalangeal joints are flexed, these muscles also can extend the PIP or proximal interphalangeal joints. Otherwise, the intrinsic muscles extend the proximal interphalangeal and distal interphalangeal joints, as I have mentioned. The PIP and DIP joints, don't forget, they flex the metacarpophalangeal joints. The complex arrangement of the on the dorsum of the hand provides the necessary synchrony and balance between flexes and extensors during the multiple precise motions of the metacarpophalangeal, the proximal interphalangeal, the distal interphalangeal joints working in concert. So you can see how the muscle, the anatomy of the hand. The main insertion of the extrinsic extensor muscle tendon is through the center at the base of the middle phalanx. The intrinsic muscles join with the extrinsic extensors through the interdigitating transverse and oblique fibers of the dorsal apparatus extend the PIP and DRP. طلعوا على الاكستنشن، طلعوا على السلايد يلي الصورة اللي حطيت لكم اياها تحت. You can see that there is a slit in these common intrinsic muscles which are acting on the proximal interphalangeal and interphalangeal joints to extend them. And you have the common extensor passing in between them to go and insert at the dorsal and basal aspect of the distal phalanx. And it is this tendon which ruptured during a mallet finger when a tennis ball hits the distal phalanx and promotes a rupture. On the other hand, on the flexor aspect, it is the profundus tendon which is ruptured in the jersey finger. Jersey and the shirt, and the patient and the individual is trying to get away. The forces on it will let the profundus rupture from its insertion, either with bone or without bone, but most commonly it is with bone, and it is called the jersey finger. Assessment of nerve function may be organized by considering groups of muscles innervated by specific nerves and testing the muscles within each group. Proximally, the median nerve, remember this, proximally, the median nerve innervates the pronata teres, the flexor carpi radialis, the palmaris longus, and the flexor digitorum superficialis muscle. Don't forget this. These are the muscles which the median nerve innervates. Now, a question that could be asked is, all the following are innervated by the median nerve, except we add the muscle, whatever muscle it may be, and that you choose that as not being a part of these group of muscles. The anterior interosseous nerve branch of the median nerve innervates the flexor digitorum profundus of the index and middle fingers, the flexor pollicis longus, the pronata quadratus muscles. The motor branch of the median nerve, the sena musculature, innervates the opponens pollicis, the abductor pollicis brevis, اللي حكينا عنهم قبل, and the superficial portion of the flexor pollicis brevis. These muscles are innervated by the median. Nerve. And in addition to the adductor pollicis, which again is innervated by the ulnar nerve. Yani, the ulnar nerve supplies the adductor pollicis and the deep portion of the flexor pollicis brevis. The median nerve is abductor pollicis brevis and superficial portion of the flexor pollicis. يا شباب هولي بدكم تحفظون. أنا ما بقدر أعطيكم أكثر من هيك, but you have to memorize them. The index and long finger lumbricals are innervated by the median nerve, running with the sensory nerve branches of the median nerve to the index and middle fingers. The ulnar nerve innervates the flexor carpi ulnaris, the flexor digitorum communis of the ring and little fingers. Within the hand, the ulnar nerve innervates the hypal, the flexor digiti quinti, and abductor digiti quinti. The deep motor branch of the ulnar nerve innervates the dorsal and palmar interosseous muscles, the ulna 2 lumbricals, namely the ring and little fingers, and the deep portion, as I have repeated, muscles. A patient who has an ulnar nerve lesion interfering with the nerve supply of the adductor pollicis will have a positive test, which is called Froment sign. It phalanx during opposition, it remains straight. And if you hold the piece of paper between the two fingers, you see that it is weak. Why? Because the adductor pollicis is weak. It's absent. There is no function due to the nerve root lesion. Am I clear up to now, ya Shabab? Look at this is a very difficult topic, and I want you to ask questions if things are not clear. The triceps, the brachioradialis, the extensor carpi, radialis longus, and brevis, the supinator, and the anconeus muscles. The posterior interosseous division of the radial nerve then innervates the extensor digitorum communis, the extensor indicis proprius, the extensor digiti minimi, the extensor carpi ulnaris, abductor pollicis longus, and extensor pollicis longus and brevis. So you can imagine how much you have to memorize. Nerve, help of muscles to supply. Once you've done all these, once you've studied all these, you have to learn how to rate the paralysis. Muscle strengths should be graded according to the Medical Research Council of Great Britain, the grading system. And if I recall correctly, it was 7. 7 used to come on a monthly basis to our army hospital and evaluate soldiers. A 5/5 being a normal strength, but with ability to resist fair amount of resistance. A 3/5 is resistance against gravity. 2/5 is resistance with gravity eliminated, and 1/5 only a trace. So you have to know this grading system. Contraction or spasticity of intrinsic muscles creates increased tension on the dorsal hood. Coming to the swan neck deformity, this develops with the proximal interphalangeal joint in hyperextension and the MP or the metacarpophalangeal joint and distal interphalangeal joint in flexion. Laceration of the central extensor tendon proximal to its insertion into the middle phalanx allows the lateral bands to slip voluntarily. يعني إذا تعملوا شيء حدا جرح على posterior aspect of the proximal interphalangeal joint, the central slip is cut. The lateral bands have nothing to anteriorly on both sides, and this leads to boutonniere, the French from buttonhole, PIP, or proximal interphalangeal joint deformity. This is a swan neck deformity. All the extensor bands slip to the dorsal aspect. And as a result, you'll have hyperextension of the proximal interphalangeal joint and flexion of the metacarpal phalangeal joint and the distal interphalangeal joint. This is the swan neck deformity. I repeat, swan neck deformity. This the boutonniere deformity. The lateral bands have slipped to the front. The central band has been torn. There is no support to keep the lateral bands in position, so they slip. And other conditions that can cause this is in rheumatoid arthritis, where you have weakness and minor tears. With time, it becomes a complete tear. And if you look at this slide on the right-hand side, you see where the lateral bands are slipped from both sides and the central band is torn. This is a boutonniere deformity. After traversing the Guillain Canal, the ulnar nerve branches into the superficial cutaneous branch that provides sensation to the ulnar aspect of the palm and the ulnar 1.5 fingers, and the deep motor branch that supplies the hypothenar muscles. This shows you the ulnar nerve. The ulnar nerve lies medial to the vessel. So if you're asked this, you have to know that the artery is more lateral, and it is in Guillem's canal, which is bound by the hamate ligament, the ligament between the hamate and the pisiform, and the bone posteriorly. And this gives a deep branch that supplies the hypothenar muscles and the sensory branch that supplies the 1.5 fingers on the medial side, namely the small and the ring gap. The ulnar nerve then travels the deep palmar arch, supplying all the interossea, the third and fourth lumbricals, the adductor pollicis that I have spoken about, and deep head of the flexor pollicis brevis. The median nerve supplies the remaining thenar muscles and the first and second lumbricals, and it provides sensation to the thumb and the radial 2.5 fingers. But as an ulnar nerve, 1.5 medial fingers. The median nerve, 3.5 lateral fingers. Sensation. The median nerve supplies the lateral 2 lumbricals. The lumbricals arise from the profundus tendon. Okay? What about the lecture? Sorry. Now, the points to know about the anatomy. I want you to know these points. It's not only the anatomy. Okay? You have to know that. This is a very important slide. Okay. Speaking about the let's see, the A2 and A4 pulleys, they are the most important for biomechanical efficiency of digital flexor retinaculum pulley system. إذا بتطلعوا على البولا aspect of the hand, you have the A2 and you have the A4 pulleys. You have the A1, A2, 3, but these are the two most important pulleys which form about a tunnel in which the flexor tendon to the finger passes. If you cut these pulleys, you'll find that you will end up having bowstringing of the tendon. We try to avoid cutting these when we're doing surgery on the tendons. Okay, be very careful about this. The radial nerve of the thumb is at risk, and I'll tell you these are warning signs, and that's why I put this slide in. But I'm trying to uncover, let me see if I can uncover. Yeah, I can. The conjoined lateral bands are stabilized by the triangular ligament, which prevents volar subluxation extensor tendon, and as a result, these lateral bands slip and the joint subluxes or angulates dorsally, leading to the botonier default. The radial nerve of the thumb is at risk during trigger thumb release. This is very true in both adults and children. Why? Because of its oblique orientation overlying the A1 pulley. هذه اللي بدنا ننبهكم إياها إنه children, most of the trigger thumbs usually subside after 1 to 2 years. But if they don't subside, you have to do a release. When you're doing a release by anterior approaches, you have to pay attention very careful to the radial nerve. The lumbricals course palmar to the deep transverse intermetacarpal ligaments, whereas the inchi muscles are dorsal to the ligaments. This is an anatomic point of view. Finally, 5, extensor indicis proprius and extensor digitorum minimus tendons typically are located ulnar. You see, as you go in, there's a question you always ask. If you want to transfer the indicis proprius, where is it? Is it ulnar wise or is it radial wise? Well, you have to know that these are ulnar to the common extensor tendons. Okay, so you have to pay attention to this. This shows you the various pulleys. You can see the A2 pulley, which is most important, and A4 pulley. These are the ones in blue. And if these are torn, then the tendons will bowstring. And this would weaken the function of the finger, and it will be ugly looking. Pay attention where the A1 pulley is, where the A2 pulley, and where the A4 pulley is. The ulnar nerve is medial to the volar and volar to the ulnar artery at the level of the wrist. We mentioned this. The classic order of innervation for the posterior interosseous nerve from proximal to distal is the extensor carpi ulnaris, the digitorum communis, the digitorum minimus, and abductor pollicis longus, extensor pollicis longus, extensor pollicis praedensa indicis proprius. Okay, so you have to know these. The deep head of the pronator teres separates the ulnar artery and median nerve superficially. This is in anatomic finding. The interosseous membrane runs from proximal to radial to distal, and this is the Essex-Lopresti lesion that we keep on discussing it when we have fractures of the head of the radius, whether the interosseous membrane is torn, and then we call this an Essex-Lopresti lesion. Inadequate surgical decompression of the volar compartment of the forearm is often the result of incomplete decompression of the flexor digitorum profundus and pronata quadratus, which may be anatomic subcompartments within the volar forearm. So whenever we have an inadequate decompression, we should think of it, that it could be at the level of the flexor digitorum profundus and or the pronata quadratus. Be careful. So this finishes our section on anatomy. Are there any questions? PCSLE. Am I clear?
Yes, clear.
Yes? Okay. لأن ليش بدي لكم, this is the difficult part of this lecture. You have to know the anatomy of the hand. You have to know, for instance, I didn't tell you that the thumb functions 60% of the hand. The rest of the fingers are 40%. So you have to know everything about the hand. If when I'm talking, find that there are certain points I should mention about the hand. You have to know about the individual tendon, about the pathomechanics of how the swan neck deformity is formed or the Botonian deformity. You have to know about the jersey finger and the mallet finger, the mechanism in which they are formed. One is by direct impaction of a ball on the DIP joint when it is in extension and forced into flexion, while jersey finger is the middle finger, which is the longest finger, catches on the shirt as the player is running away and they get the rupture. And you can have rupture, which is up to the small interphalangeal joint, or it can even reach the region of the palm and to fetch it out early to be able to do so. Now, physical examination. Inspection. Examination of the hand should begin with inspection. Some information can be obtained by observing pseudomotor function from the autonomic nerves that control sweating, as revealed by sweatiness of the finger palps. Vascular conditions can be assessed by noting the color of the fingers. If you look at this, the vascular color duplex, blood supply of small vessels measuring from 2 millimeters, and this will help you in patients who have insufficiency of supply. A vascular arteriogram is a gold standard, of course, but it is invasive, and it evaluates the arch of the aorta to the digital arteries. It would give us details, but you have to keep in mind that this is an invasive. Now, which is coming very common, is the magnetic resonance angiography. And this is investigational for the hand. It's comparable to angiography for medium and large vessel disease. You have to know that in the hand we have 7 vascular conditions, and one should keep these in mind. You can even have embolic disease, and you have to know that whenever you have an embolus in the hand, 70% of these are of cardiac origin. They can also come from the subclavian artery. The treatment is first line. You can give a tissue plasminogen activator for small vessels within 36 hours. Or second line, you can do an embolectomy and give heparin in these cases. Vascular arteritis, you can have thromboangiitis obliterans, and this is quite common in smokers, and is known as Berger's disease. And the treatment we advise is stop smoking. Recently, I've had an army soldier coming into my clinic, having a box of cigarettes in his shirt and with the cigarette in his hand. And blood supply to his hand. And he said, "Doc, what should I do? I have this." I told him the best thing to do is to go and burn all your cig packs and forget about smoking. There is another form which is known as giant cell arteritis, and this is diagnosed by biopsy, and you have to treat this with steroids. Also, you have polyarteritis nodosa, and this occurs mainly at the bifurcations of the digital arteries. Now, how do these patients present? If you get the patient coming to you like this, look, tells you, "Doc, yesterday my tip of the finger was perfectly normal. Look at the way it has become. It was numb and painful, and now it's becoming senseless." Well, when you get these patients, you should, in a warm environment, they should stop smoking. There is a medication you can give them, nifedine treatment, and you can give them topical nitroglycerines, Trental, Plavix, and acetylsalicylic acid perzentine. All these have been given to these patients. But the main thing is prevention by smoking. Now, vascular operative treatment, small vessel disease, digital vasectomy is effective. It improves the flow in the small vessel disease, such as Raynaud's phenomena and scleroderma. Medium vessel disease, you have to give acute streptokinase or thrombectomy, and if it's chronic, you should try and do a vein graft. There is a condition which is called hypothena-Hammer syndrome. This is quite common among laborers. And now, over here, if you look at the X-ray, you see that the arteriography does not show uptake in the ring finger. So you have to treat whatever obstruction, apply a graft, and reconstruct. This is, I think, is more the job of a vascular surgeon. But you should know that if this occurs, this is what should be done. There are workers who have minor injuries of the hand, and later they have swelling and pain, and as a crush blood. And if you put your stethoscope, you see that there is a and this is an aneurysm that could occur secondary to trauma, and the treatment is and don't forget about Raynaud's disease. It's an ischemia. It is often bilateral. You have to rule out occlusive diseases. There's no trophic changes. Symptoms are present for 2 years usually, and these are more common in females. Come to compartment syndrome, and we all know what compartment syndrome is. You know, in the forearm there are 3 compartments. In the hand, you have around much argument between 9, say 9, some say 10, some say even more compartments. The compartments in the forearm are the volar compartment, the dorsal compartment, and medially you have the mobile wad. Okay? These compartments you can have an increase in tissue pressure following crush injuries, and you have a close. I mentioned to you. Now, frostbite from snow, cold, you need rapid rewarming and you put the hand in a 40 to 44 degree bath centigrade, allowed demarcation. You should avoid early amputation, and you should not give anticoagulation because it doesn't help. Lastly, Volpin's contracture is an ischemic injury to the muscle causing contracture. As I mentioned, that there are 2 muscles which are involved most, which is the flexor digitorum profundus and the flexor pollicis longus. These are most affected. You have the release of contraction. You have to exercise the dead muscle. Yeah, you can do in the chronic cases a flexor slide or fractional lengthening of the contracted muscles. The signs that can be evaluated during inspection include swelling, as we mentioned, or lumps, or changes in color of skin, lacerations, scars from injuries or previous surgeries, and any hand deformity. The posture of the digits and the wrist may signal tendon or bone disruption. Normally, a cascade of increased digital flexion is noted when ulnar digits are observed next to the radial digits. You have to pay attention. This is the normal cascade of the hand. You have to pay attention where the small finger is. This is the function or the anatomical position of the hand. Control of digital posture requires a complex balance of extrinsic and intrinsic muscle forces. Extrinsic muscles have their origin outside of the hand and their insertion on the hand or corpus, whereas the intrinsic muscles have both the origin and insertion within the hand. The extrinsic muscles are either flexors or extensors, and the intrinsic muscles contribute to both digital flexion and extension, as I previously mentioned in the anatomy section. One should look at the nails, as they may show signs of atrophy or disease. For example, psoriasis, which is sometimes associated with typical arthropathy, or grooved nail, which is a telltale feature of a ganglion cyst. And wrist and forearm are gently palpated. The temperature and texture of the hand should be noted. Circulation is assessed by capillary refill when the skin is blanched adjacent to the nail. Circulation should return within 2 seconds. Swelling or thickening may be in the subcutaneous tissue, a tendon sheath, a joint, or one of the bones. If felt, the underlying tendon should be moved by flexing and extending the relevant finger to discover if the nodule is attached to the tendon or its sheath. And if it's attached to the sheath with flexion and extension, it does not move. But if it's attached to the tendon, of course it is moving, such as occurs in the trigger finger. Areas of tenderness on palpation are carefully noted and linked with the underlying soft tissue or bony structures. The passive and active range of motion of the shoulder, elbow, forearm, wrist, and hand should be evaluated. The normal range of motion of the wrist and fingers is summarized in the next table. You should know that the elbow extension is from 0 to 135 degrees. You should know that pronation and supination is 90-90. Wrist flexion, 80-70. Radial deviation in the radial deviation is 20. Ulnar deviation is 30 degrees. You have to know these ranges of motion. Metacarpophalangeal joint, 0 to 90 degrees on flexion, extension. The proximal interphalangeal joint, 0 to 110. The distal interphalangeal, 0 to 65. Now, coming to the thumb, the carpometacarpal joint, extension and flexion is 50-50. Abduction and adduction is 70 degrees to 0 degrees. Metacarpophalangeal extension flexion up to 90 degrees. The interphalangeal joint up to 90 degrees. So you have to know these ranges of motion. Motor function can be impaired due to either tendon or muscle injury or nerve dysfunction. The integrity of individual tendons and or muscles should be documented. The tenodesis effect during wrist flexion extension is helpful to evaluate tendon rupture. The flexor tendon digitorum profundus to each finger is tested by holding the PIP joint in extension and asking the patient to flex the distal interphalangeal joint. Likewise, the flexor digitorum sublimis should be tested. Likewise, the flexor pollicis longus should be tested to rule out any rupture, which can be irritated by an exostosis on the navicular, and it can rupture it, and it becomes called the Mannerfeld syndrome. We love this question, the Mannerfeld syndrome. One should test the digitorum profundus, the flexor. You should test the superficialis. This is how we test for the profundus. We put our two fingers, we apply pressure, and ask the patient to flex the DIP joint. We should test the superficialis. Now we know that the tendons are joined to each other by means of bands. When we extend the other fingers, the function becomes solo on the PIP joint, which is supplied by the flexor digitorum sublimis. And that's how we can tell whether it's ruptured or not. Extension of the extrinsic muscles located outside the hand is tested by asking the patient to extend the metacarpophalangeal joints of the fingers. The PIP, or proximal interphalangeal joints, and the DIP, joint extension, is mainly achieved by contraction of the intrinsic muscles location inside the hand. Therefore, the best way to evaluate extrinsic extensors function is by holding the metacarpophalangeal joints in flexion and asking the patient to extend his or her metacarpophalangeal joints. Dorsal interosseous muscles is screened by asking the patient to spread the fingers for abduction. The examiner assesses the strength of muscle force while palpating the contraction of the hypothenar and the first dorsal interosseous muscles. Palmar interosseous muscles are functioned by asking the patient to cross the fingers. Assessment of nerve function may be organized by considering groups of muscles innervated by specific nerves and testing the muscles within each group. هذه اللي قلت لكم اياها الميديان nerve supplying the proximal muscles. You have to evaluate these in each group, and then you can decide where the nerve is cut. You can decide which nerve is cut and what you should do. Proximally, the median nerve innervates, as I said repeatedly, the pronata teres, the flexor carpi radialis, the palmaris longus, the flexor digitorum superficialis. You have to know this, that this is the median nerve. If it's cut, these muscles won't function at that level. The anterior anterosseous nerve branch of the median nerve, we mentioned about this. What muscles they supply, it will tell you whether the anterior anterosseous is cut or not by losing the function of these muscles. So keep these in mind. Okay. Let us see what we have. What about the sensory function? Examination of the sensory function requires evaluation of the integrity of the median, ulnar, and radial nerves, as well as component proper digital nerves to each finger. Okay, has an autogenous sensory zone, an area of the hand supplied predominantly by that nerve. And this is what I'm speaking about. I got this from the review course by the AAOS. You have to know where does the ulnar nerve supply and where is the solo zone by the ulnar nerve. You have to know about the radial nerves. You have to know about the median nerve, about the sensation supply of the hand. The autogenous zone of the median nerve is the pulp of the index finger, whereas the ulnar nerve exclusively carries sensory fibers from the pulp of the little finger, is the median nerve. Pulp of the small finger is the ulnar nerve. The skin on the dorsum of the first web space is innervated by the superficial branch of the radial nerve. You have to know these. If you don't, then you won't be able to tell or examine your patient properly. So you have to know well about the sensory distribution in the hand. The light shading, the ulnar nerve, the medium shading, the radial nerve, and the darkest shading is the median nerve. So you have to know this. Look at this. Each of the shading tells you which nerve is the supply. The light shading on the ulnar aspect is the ulnar nerve. The dark shading on the right-hand side is the median nerve, and then the intermediate shading is the radial nerve. So keep this in mind, please. Okay. Now, what about two-point discrimination value? It is the smallest distance between the 2 points that the patient can correctly detect in 2 out of 3 trials. The static 2-point discrimination is normal if the distance is less than 7 millimeters. يعني بتاخدوا إبرتين أو is a higher clip, you divide it, make it at a certain distance, and you examine. If you see that the patient can identify it at a distance of 7 millimeters, this is normal, even if it's less than 7. And 7 to 14 millimeters is impaired, and 15 millimeters or greater is completely damaged. You have to know about the boutonniere deformity. Inspect the hand for atrophy of the sena muscles innervated by the median nerve, and this you have to think of a carpal tunnel syndrome, or hypothena and intrinsic muscles innervated by the ulnar nerve. The intrinsic muscle weaknesses causes atrophy between the metatarsals and dorsum of the hand. Look at the nails for evidence of picking or signs. This can occur in psoriasis. Okay? Palpate the bony landmarks and any swelling or osteophytes. At the wrist, the radial and ulnar styloid processes are palpable. The radial styloid is approximately 1 centimeter distal to the ulnar styloid. The dorsal tubercle at the distal radius, this is called listus tubercle, and we call this the curse of rheumatoid arthritis. Why? Because the tendons rub against it, and they can get ruptured. Even in Colles fractures, when you have irregularity, the tendon can rub over there and the patient will have a rupture. It functions, the listus tubercle, the extensor pollicis longus, and is a marker for surgical approaches. The pisiform on the volar aspect of the wrist is a landmark for the ulnar nerve and the artery if you want to localize it. The zero starting position for determining wrist motion is the forearm in pronation and the carpus aligned with the plane of the forearm. In young adults, normal wrist motion is approximately 75 degrees of flexion and 75 degrees of extension. And 20 degrees of radial deviation and 35 degrees of ulnar deviation. How much ulnar deviation is present. You have to know how much radial deviation is. You have to know how much opposition, or if there's any limitation. You have to know if during opposition you are not able to flex the interphalangeal joint. And as a result, you'll have Froment sign. So you have to know these. Finger joint motion occurs primarily in the flexion extension plane, with flexion accounting for most of the motion. The wrist should be in neutral position when the finger or thumb flexion is measured. When the wrist is flexed, the extensor digitorum communis and thumb extensors and are under tension, thereby limiting finger and thumb flexion. Okay, flexion and extension can be measured at the MP, the PIP, the DIB joints, but from a functional perspective, finger flexion is a composite of movement, of motion from the three finger joints. Ask the patient to touch the distal palmar crease. In young and middle-aged adults, the fingertip should touch this crease. Lack of full finger flexion can be quantified by measuring the distance from the fingertip to the distal palmar crease. You can record this. The planes of the thumb motion are flexion, extension, abduction and adduction, and opposition. Opposition is a composite motion at the carpometacarpal joint, MP, and interphalangeal joints that is critical to daily activities. The disability ratings, opposition is valued as 50% to 60% of thumb function. In normal opposition, the tip of the thumb touches the base of the little finger. In normal opposition, the tip of the thumb touches the base of the little finger. Impaired opposition can be quantified by measuring the distance of the tip of the thumb to the base of the little finger. All thumb joints move in flexion and extension, but this range is difficult to quantify at the carpometacarpal joint. Flexion at the thumb MP joint is typically 50 to 60 degrees. Extension is not typically observed at the thumb MP joint. Normal thumb interphalangeal motion in young adults is 55 to 75 degrees of flexion and 5 to 10 degrees of extension. To assess the strength of the wrist flexors, the most powerful of which is the flexor carpi ulnaris. This resists the patient's effort to flex the wrist with the elbow flexed to 90 degrees and the thumb and fingers in the extended neutral position eliminates the action of the finger flexors. You have to evaluate each of the muscles, each of the functions, especially when you know what is the function of that muscle. To test wrist extensors, the most powerful is the extensor carpi ulnaris, the extensor carpi radialis brevis. Resist the patient's effort to extend the wrist with the elbow flexed at 90 degrees and the fingers flexed. Eliminates the action of the finger extensors. So you have to do these tests completely. You have to test the FTP, the flexor sublimis that we've repeatedly stated. You have to know what ape hand nerve palsy. This shows you the median nerve palsy and ulnar nerve palsy. The hand in median nerve palsy, you see that there is flexion of the fourth and fifth finger, while the other fingers are straight. And this is the hand of benediction, while lower hand occurs in the ulnar nerve, and the dropped hand occurs in the radial nerve. To pinch a piece of paper while you pull on it. Weakness of the adductor pollicis results in flexion of the interphalangeal joint of the thumb, and this is Froment's sign. This is Froment's sign. Okay? When pinching a piece of paper between the thumb and index finger, the thumb of the interphalangeal joint will flex if the adductor pollicis is weak. This occurs in ulnar nerve palsy. Assess the ulnar nerve sensation at the volar tip of the little finger. If the ulnar nerve entrapment or laceration occurs above the wrist, the sensation may be lost on the dorsum of the hand. If the ulnar nerve is divided distant to the mid-forearm, all the engines are paralyzed except for the first and second lumbricals and the thenar muscles. Lack of intrinsic muscle function of the ring and little fingers causes an ulnar claw hand or a hand of benediction with the fourth and fifth fingers, hyperextended at the MP joints and flexed at the PIP joints and DIP joints. The intact lumbricals to the index and long fingers provide enough the nerve is gone. And well, over here you have the lumbricals being intact and the ulnar nerve is gone. at or proximal to the elbow, clawing of the ring and little fingers does not occur because the flexor digitorum profundus to these fingers is also paralyzed. A distal forearm laceration of the median and ulnar nerve results in complete claw hand because all intrinsic muscles are paralyzed, but the extrinsic flexors and extensors are intact. Are there any questions? And I'd like to take a 2 minutes rest for my voice.
Okay, no problem. Yeah.
I know that there's not many people. There is?
No, they are well informed and they hear you. And we are all will go ahead, take your rest and return again.
It's quite difficult, but you have to memorize many components. Thank you. نجرب يا أخي، عم نجرب. عم نجرب نهون لكم إياها.
Okay, thank you.
Studies. A number of studies may be helpful in establishing the proper diagnosis in a patient with hand or wrist pain or disorders. The choice of technique should be based on a careful history, physical examination. Radiographic evaluation includes posterior, anterior, and lateral films. The importance of obtaining a true lateral radiograph of the finger and the wrist cannot be overemphasized because many disorders, particularly interphalangeal joint, subluxation, and carpal instability, are not evident on oblique views. Oblique views may be useful in defining phalangeal fracture patterns. Tangential views are useful in assessing a carpal-metacarpal boss or a mass of the dorsal bone. The carpal tunnel view may allow visualization of a fracture of the hook of the hamate. Stress views allow assessment of ligamentous stability. This is particularly useful in the evaluation of collateral ligament stability of the thumb in the phalangeal joint, mainly spinal lesions. But they are rarely used nowadays due to the high sensitivity tissue injuries. Electrodiagnostic studies include both nerve conduction studies and electromyography. Nerve conduction studies measure both motor proximal to distal and wrist, and is critical to evaluation of joints such as the distal radio-ulnar joint. The relationship of the distal ulna to the sigmoid notch should be viewed in pronation, neutral, and supination. CT scanning may be helpful in evaluating displacement as well as healing of scaphoid fractures and in surgical planning of distal radius fracture. Magnetic resonance imaging provides visualization of the soft tissue structures such as ligaments and tendons. The integrity of the transverse carpal ligament may be evaluated, which is particularly helpful in patients with persistent symptoms following carpal tunnel release. Evaluation of tumors and avascular necrosis is also facilitated by MRI. MRI scans also allow visualization of many triangular fibrocartilage complex, TFCC, and intercarpal ligament tears. Ultrasound. The applications of ultrasound for diagnosis of musculoskeletal conditions have been significantly expanded over the past years. While ultrasound was first used as a diagnostic tool for detection of foreign bodies following trauma, nowadays it is mostly used as a diagnostic modality for tendon or ligament lesions, such as thumb, ulnar, collateral ligament ruptures. Another application of ultrasound that has been recently proposed is in patients with nerve compression neuropathies, specifically in cases of carpal tunnel syndrome. Ultrasound can be used as a confirmation study in patients with equivocal signs having a good sensitivity specificity. Although the musculoskeletal dynamic nature of the exam, early, easy use, its main disadvantage is that its diagnostic capacity is operator dependent. Bone scan. The technetium 99 methylsilene diphosphonate bone scan is a useful physiologic test in the evaluation of unexplained hand or wrist pain. This test can rule out bone involvement and can be used to localize inflammatory processes for further study with CT. Wrist arthroscopy. Arthroscopic examination of the wrist allows for direct visualization of articular surfaces, carpal and intercarpal ligaments, and the triangular fibrocartilage. The effect of stress maneuvers on be debrided. Intra-articular fracture of the distal radius may be anatomically aligned and pinned. A direct observation. To avoid stiffness of the metacarpophalangeal joint in any hand fracture, immobilization should always place the metacarpophalangeal joint at 70 to 90 degrees of flexion. And this is an intrinsic plus position. Let's now come to individual. Now it becomes more interesting. Now we're going into conditions. Decurvin stenosynovitis, I'm sure you all know about it. It is the most common cause of tendinitis on the extensor side of the wrist. It involves swelling or stenosis of the first dorsal compartment tendon sheath, which surrounds the extensor pollicis brevis and the abductor pollicis longus. It most commonly occurs in patients who have one or more additional anomalous tendons within the compartment. A septum within the compartment that separates and narrows the space for the extensor pollicis brevis and the abductor pollicis longus. When you have this septum, you have much less pollicis brevis and abductor pollicis longus to pass through. Therefore, they are irritated and they will complain of. This disorder most commonly occurs in middle-aged women and is frequently brought on by repetitive thumb motion. Teno constricts the tendons as they glide within the sheath. Patients note pain of the radial styloid that are aggravated by the use of the thumb. Now, if you look over here on the right upper hand, you see the examiner is doing the Finkelstein test. Flex the thumb and the wrist and put it in ulnar deviation. The patient would complain of pain, especially if they have narrowing of the sheath. This pain does not exist in normal individuals. Crepitus may be sensed as the compartment is palpated during thumb motion. The Finkelstein test is diagnostic with exacerbation of pain when the thumb is flexed and the wrist is then placed in ulnar deviation. Radiographs are typically normal and are used to exclude other possibilities, such as fracture of the scaphoid, where you have tenderness in the region of the anatomical snuff box, or arthritis of the wrist, or even thumb carpal. If this treatment fails, a corticosteroid injection should be given in the tendon sheath, not in the tendon, in tendon sheath. Why? Because if you go to let this patient be at risk for having surgical treatment to release the area of stenosis is indicated for relief of persistent symptoms. Anomalous longus are commonly noted. You have to release all these. The most dorsal tendon of the compartment should be identified as the extensor pollicis brevis. Otherwise, a separate septum for this tendon may be overlooked. Complications of surgery include failure to completely decompress all tendons within the sheath and the injury to the superficial radial nerve. The superficial radial nerve that passes in just in line with the first extensor compartment. Other potential but less common areas of the wrist tendinitis include the flexor carpi radialis, the extensor pollicis longus, the third compartment, the extensor digitorum communis, the fourth compartment, the extensor digiti minimi, the fifth, and the extensor carpi ulnaris, the sixth compartment. Dipuytren's contraction or disease. Dipuytren's disease is contraction of the palmar fascia. The pathologic process begins with proliferation of fibroblasts and type 3 collagen to produce cords and nodules in the dermis and skin. Predisposing factors include the male gender, infections, trauma, and possibly smoking. A genetic autosomal dominant predisposition has been noted. Penetrance is variable, however, as indicated by the fact that the family history is positive and less than 10%. To the other fingers. It consists of fibroblasts and type 3 collagen. It's thick, you have to excise it. You have to pay attention to the digital nerves as you're doing so. And the problem with this is there is a high incidence of recurrence. The disease is uncommon before 40 years of age. A typical presentation is a 40 to 65-year-old patient who notifies or notices a painless nodule near the distal palmar crease on the ulnar side of the hand. The cords initially may be tender and may occur in other locations. The nodules may remain confined to the palm and cause few symptoms. However, the disease may extend into the fingers with progressive, albeit variable, flexion contraction of one or more digits at the MP joint. In more severe cases, the PIP joint. Most often involved, followed by the little, the long, thumb, and index fingers. Concomitant involvement of the plantar fascia, which is known as the leather hose, and the fascia of the penis, which is known as Peyronie's disease, both occurs in less than 3% of individuals with Dupuytren's disease. Early treatment of a nodule in the palm consists of reassurance to functional impairment. Splinting is ineffective. Recent research on collagenase injection has shown promising results. Surgery is indicated for significant contractures that interfere with extension of the fingers and functional activities such as retrieving objects from a pocket. The goals of surgical treatment are to excise the diseased tissue and release the contractures. However, the procedure is technically demanding, may be complicated by nerve injury, skin slough, and recurrent contractions. Ganglia of the hand and the wrist are well known to everyone. The most common benign tumor of the hand and wrist is a ganglia. We don't even call it a tumor. The degeneration or tearing of a joint capsule or tendon sheath. This shows the most common area of a cyst to occur is in the scaphoid lunate area on the dorsal aspect of the wrist. The lump may be asymptomatic or may cause aching that is aggravated by activities requiring repetitive wrist movement. Examination reveals a firm cystic mass that transilluminates when a penlight is pressed against its side. The second most common site of ganglia is the volar radial aspect of the wrist between the flexor carpi radialis and the radial styloid. These ganglia originate from the capsule and scaphotrapezial joint and may wrap around the radial artery. A volar retinacular ganglia of the flexor tendon sheath typically is just proximal to the metacarpophalangeal flexures of the finger. This seed ganglia is a small, firm nodule that is frequently tender when gripping objects, but does not limit or move little finger flexion extension. Mucous cyst, a type of ganglion that develop at the nodes and most spontaneously recede, and observation is appropriate for patients with minimal symptoms Aspiration is often successful in the treatment of volar retinacular ganglia and may be useful in the treatment of dorsal wrist ganglia, although recurrence rates are high, and is used with caution in volar wrist ganglia or mucus. Surgical excision includes joint capsule attachments. The risk of recurrence after surgery is 5 to 10% if the procedure is combined with 2 weeks of immobilization. Because this exists, the DIP joint, distal and phalangeal joint, requires careful removal of the cyst and any associated osteophytes, because it commonly occurs together with an osteophyte. Nerve entrapment syndromes at the wrist. Carpal tunnel syndrome is the most common in middle-aged or pregnant women. The syndrome is often idiopathic, but predisposing factors that reduce available space in the carpal tunnel or affected peripheral nerve function should be investigated. These factors include tenosynovitis of the adjacent flexor tendons due to rheumatoid arthritis or overuse syndrome, edema results from pregnancy, or hypothyroidism and peripheral neuropathy caused by diabetes mellitus, alcoholism, or other conditions. The differential diagnosis includes cervical radiculopathy that affects the C6 nerve root, median nerve entrapment at the elbow, ulnar entrapment at the wrist and wrist arthritis, ulnar nerve entrapment at the wrist canal is less common than ulnar entrapment at the elbow. Predisposing factors include space-occupying lesions such as ganglia or repetitive trauma, such as trauma produced by or that caused by repetitive pressure associated with extended crush ambulation. The differential diagnosis includes cervical radiculopathy that affects the C8 nerve, thoracic outlets, or C8 nerve root typically causes numbness of the dorsum of the hand. You have dog, cat, and human bites. They account for approximately 1% of all emergency room visits. Dog bites account for approximately 80 to 90% of animal bites, but only 10% of wounds from dog bites become infected. In contrast, cats inject bacteria deep into the tissues. The causative organisms of the dog and cat bite infections are similar. Pasteurella multocida is found in 50%. of wounds from cat bite and in some dog bite wounds. Other bacteria commonly found in dog and cat bite wounds include a hemolytic streptococci, Staph aureus, Bacteroides species, Fusobacterium species. Human bite wounds often occur at the fingers, a direct injury, or metacarpophalangeal joints, an indirect clenched fist injury. يعني واحد عم بيضرب بوكس للتاني. Because of the circumstances of بيستحي يقول انه ضربته بوكس ومن هيك اللي صار فيه. And the laceration lesions commonly delay evaluation. بيستحوا يجوا يقولوا طب بوكس بيدرسوا ايدي ما بيحبوا يحكوا. So most of them are late. As a result, many patients with human bite wounds do not present until a well-established infection has developed. Gram-negative inert organisms, particularly Echinella corrodens, are common in human bite wounds. Examination should assess location, swelling, erythema, and purulent discharge. Evaluate possible tendon or neuromuscular dysfunction. Provide appropriate tetanus prophylaxis and debride necrotic tissue. Most bite wounds should not be closed, primarily pending culture results. Treat animal bites with oral or intravenous penicillin, sulbactam. Penicillin and a cephalosporin are the standard initial antibiotic therapy for human bite wounds. Unique hand infections. Flexor tendons of the fingers and thumbs are surrounded by tenosynovial sheath that extends from the distal palm to the DIP joint. Infections within the sheath usually develop puncture wounds. يعني تطلعوا بالإيد, if you look at the hand, you look at the tip of the small finger and the thumb, you see that there is a sheath. These unite around the wrist, and this is called the horseshoe abscess when it occurs. Because the sheath is closed space with limited blood supply, an infection rapidly becomes an abscess. This of the thumb and little finger flexor tendons extends to the radial and ulnar bursae. So infection in these tendon sheaths have the potential to 48 hours after injury. Examination reveals diffuse swelling of the finger, maximal tenderness over the tendon, a finger held in semi-flexed position, and marked increased pain on passive extension of the digit. Patients require prompt treatment for prevention of tendon adhesions and necrosis. If the infection is recognized early, parenteral and antibiotic therapy that covers both staph and stay. Most patients, however, require surgical drainage supplemented by closed tendon irrigation and appropriate intravenous. The fingertip has vibroreceptors that provide support for pinching and grasping activities. These receptors create many small compartments which a felon space infection may develop. A felon typically the wound most commonly involves the index and is characterized by intense swelling on the osteomyelitis of the distal phalanx. Surgical drainage can be performed through a central incision and extends from the flexing crease to the fingertip. When an abscess collection is identified or through a mid-axial incision when the location of the pus is not visible. Mouth incisions that extend across the tip of the finger causes a painful scar and should be avoided. The wound should be packed within herpes simplex virus infection can affect the fingertip and may cause swelling that should be differentiated from a felon. Herpetic whitlows have vascular lesions and typically have less erythema and swelling than occur with felons. Lesions occur in adults and children and are more common in men because they deal with saliva. Predisposes the patient to secondary infection. Paronychia is inflammation of the nail fold, the gutter along the ring. Infection and often occurs in people whose hands are immersed in water for long periods. It also may be associated with nail cosmetics. Infections can be acute or chronic. Acute infection is usually with Staph aureus and begins as a cellulitis and progresses to an abscess at nail margin. Most often involve Candida species. I want to take a 5 minutes break here because my throat is hurting. Thank you. 5 minutes.
Okay, no problem.
Speaking about paronychia, we spoke that the collection occurs especially in people who their hands are at all times water, and therefore they can get an infection. Early with antibiotics. The most common organism is Staph aureus. Later stage infections require elevation of the skin fold or partial or complete removal of nail. Differential diagnosis, you have to think of a felon, mucus cyst, subungual exostosis, herpetic whitlow, and long Kia. Paronychial infections are the most common hand infections. The paronychia is a skin fold and ulnar to fingernail. The ponychium is proximal to the nail. Paronychial infections typically develop from a hangnail, an ingrowing toenail, or a poorly-performed manicure, and they also may result from fingernail biting. The treatment of acute infections with warm soaks and oral antibiotics. Incision and drainage is required after as forms. Partial nail removal may be necessary to decompress the abscess, and treatment of chronic infections includes antimicrobial agents, and maintenance of dry hands may require nail removal. This is one is the felon. You see it's of the pulp, the upper one. Paronychia is an infection of. We've spoken about these. I'm not going to go through these. Now, I just want to mention briefly about reimplantation. You have to decide which to reimplant and which are not. The thumb is the most important. Then comes the index finger. You can have ring avulsion fingers, but the nerve, the tendons, all will rupture. And in this way, an amputation might be the best treatment. Flaps, you have to pay attention. If you have a nail bed, you have to pay attention that the nail bed is not attached to the nail when you have a crush injury. You should suture a nail bed very carefully, end to end, and can use anywhere between 6 and 7 chromic loop, chromic, and use magnification. You should reinsert the nail for protection. If you get a fracture like this at the bottom in the finger, you have to reduce it, put the pin, and then do your surgery. In children, you can get type 2 injuries. You have to reduce them and then do your surgical treatment. The options for treatment of any significant injury is you can depend on direct healing, you can do primary closure, you can get full skin graft, local flap, regional flaps, and free flaps used. If you look at this wound, you should close it primarily. If you have dog ears, you should resect them on the spot. Why? Because they don't flap to cover the tip. You can do a cross finger flap to cover wounds. You can do a finger to think of two web or the thumb flap, which is shown over here. You can do a composite flap in children. It can take in 50% flap from one area and transfer it to the thumb. But the problem is that these patients would have complications in the donor side. Or you can take an eyelid flap from the same finger and translocate. Okay. You can also, in cases where the thumb is short, you can use one of the toes and translocate it. It's the second toe. Or you can use the big toe, which is more nicely presented. At times, if you need a nice flap, you can take it from the dorsum of the second digit. You have the first dorsum metacarpal artery flap. This shows it more in detail, and translocate it to the area of the thumb, which is top. You have to know how to do Z-plastics properly to lengthen the incision as you repair it. And how should you reconstruct? You should do a primary closure. You can do it. You can do a delayed closure. You can apply a skin graft, a local flap, regional flaps, and free flaps. And you should, in cases where it's essential, you should cover joints, nerves, and major arteries, and no available local or regional flap. There is a difference between grafting. The split graft contracts usually. It's less durable. It's okay for dorsal hand. It has a poor sensitivity, while full thickness have minimal contraction. It's durable. It's better in palm and fingertip and vascular bone grafts. You are the fibula if it's longer than 6 centimeters. You use the peroneal artery as the vascular component, or you can use that you have to trim the thumb if you're going to use it. This is a trim doll, but the foot, it becomes a bit ugly. You have to pay. For opposition do transfers. Okay. Flex dislocations I'm going to skip, but you have to know that in PIP dislocations, most common is where the phalanx is dorsal to the metatarsal. But you have three types: one dorsal, one flex, and one rotated. These are the three types of PIP dislocations. You have to know that if you have certain tears of the ligaments, the lateral ligaments, and there's recurrent dislocation, you can use figure of 8 splints to hold it. You have to know forget about the gamekeeper's thumb. This is very important, where you get a tear of the ulnar collateral ligament, and it comes to lie underneath the adductor tendon. It becomes what we call a Steiner lesion. These need open reduction and fixation. A collateral ligament of the thumb gives us a lot of resistance. You need to do open reduction. Don't forget about the hook of the hamate. Many times, the wrist, you have to know about the intersection. These are the conditions you have to know, but we've gone through most of them. You have to know about the intersection syndrome. You have to know about decurvance, which we've discussed. You have to know about scaphoid fractures, which produce non-union, which when operate, what to operate, percutaneous reduction. The more proximal fracture, more chances of avascular necrosis. And this shows the blood supply of the scaphoid from the dorsal ridge. The risk is high. If you have displacement more than 1 millimeter, if you have oblique fractures, if you have proximal fractures. This is the approach we use. It's the Henry approach. And if it's not united, this is the approach we use. We use a bone graft. We use the Fernandez technique to operate. You have to pay attention to this. There is something I would like to mention about trapezium metacarpal osteoarthritis. There are multiple techniques. Not all, the majority is to remove the trapezium, but the flexor carpi realis, the longitudinal half, is used as an interposition and fixation. You can do a fusion in a worker, but it takes a long time to heal. Okay? So please pay attention. Don't forget about scapholunate dissociation. And this is very important because they'll end up having a weak wrist and with time, degenerative arthritis. Okay? You see, when you have this, you'll have a dissociation between the motion of the lunate and the scaphoid. You have to know the difference between SNAC and SLAC lesions. You should know about Kienbock's disease, the stages, according to Lichtman. Know the different types of stages. And the treatment you should know and be aware of. And know about the extensive tenosynovitis, know about tears of the triangular fibrocartilage, when to repair. You have to know about these techniques. And in the Kienbock's disease, when should you shorten the ulna? When should you lengthen the ulna? When should you shorten the radius? So these are techniques you should know. I'm going very quickly. I'm so sorry, but we have so much to talk about. Don't forget about hamate fractures. Know about the triangular fiber cartilage, the two different types, type 1 and type in this skull. We spoke about ulnar.